Okay, for the forearm, we want to do an AP. In the AP position, our radius and ulna run parallel to each other. If we were to pronate the hand, the radius crosses over the ulna, and if there was a fracture right where those two bones crossed over each other, it might be missed. So we always want to do our forearms AP whenever possible, so that the bones are free of superimposition over each other. So I would have my patient extend their arm out and lean over the table. Now in this view, I am going to be including the elbow joint, and it's important that when you're including a joint that it be open. And the only way it's going to be open is if the humerus and the forearm are both on the same plane. So I will have, now again, I moved up to a 14 by 17 cassette. That's probably standard. However, I'm not going to collimate to a full 14 by 17. I want to make sure that he is rotated completely AP, that his elbow and wrist are in the same plane. I'm going to be placing my right marker. He's running down the long axis of the middle of the cassette. And my central ray is mid-forearm. I'm going to open up my collimators so that they're an inch beyond the skin line. And I am including both elbow and wrist joints. So past the carpal bones, past the elbow joint, and at least an inch on each side so that I can include my marker. I can collimate in just a little bit. That looks good. So this is my AP forearm. All right, now for the lateral, you want to have your elbow flexed 90 degrees. And in this instance, this is where you would raise the table up to meet your patient, because it's much easier for him to do like this and for me to raise the table up to him. But because our tables don't raise, I need him to lean over until his humerus is resting on the table. Okay. Right. So the hand is lateral, the elbow is bent 90 degrees, forearm and humerus are on the same plane. Right marker, centering to the mid forearm and the middle of the IR. Opening my collimation up. All right. And that is my lateral forearm. Now, radius and styloid will probably, radius and ulna will be superimposed at this end, but probably not all the way up, and that's just the shape of the bones. All right, so this is our lateral forearm. All right, all the long bones are two views only. So forearm, humerus, tib, fib, femur are just an AP and a lateral, or a PA and a lateral. Once we get into the joints, then we're also including obliques. All right, so now we're going to move on and do our 4-view elbow. Back down to a 10 by 12 or an 8 by 10, it depends on what your clinical site has. And I will start with the AP. So I need to have him lean out so that his forearm and humerus are on the same plane. He is rotated to an AP position. Place my right marker. Again, 40-inch SID. I'm going to collimate to the long axis of the IR. And I want to include about 3 inches beyond the joint in proximally and distally. All right, so that is my AP. Now for my internal oblique, the only thing I have to do is turn the hand from an AP position to a PA position. And just by rolling the palm prone, it rolls the elbow joint into a 45-degree medial oblique. So that's a simple adjustment. You just roll them medially, placing the palm flat, and his elbow automatically rolls into a 45 degrees. So if you imagine his humeral epicondyles were parallel to the tabletop, and now that line is at a 45 degree angle from the tabletop. Okay, the external oblique is probably the hardest position to do. This is where you have to be sure that you are ready to go so that your patient doesn't have to hold this position for very long. So what I will normally do is I'll cradle the arm and I'll roll him, which requires, like, he's laid his shoulder down. So that's a perfect example of how to do this. I will roll him until now the humeral epicondyles are 45 degrees externally rotated. This is not a comfortable position to maintain, so you want to be quick in your positioning. Externally rotated 45. Still shielded, I would expose. You can relax. Okay, and the final projection for an elbow series is the lateral. Lateral is done with 90 degrees flexion, forearm and humerus on the same plane. Now, keep in mind, for our AP in both obliques, my humerus was running along the long axis. So if I kept the IR like this, now my humerus is running across the short axis. So when you're looking at all these finished images on a view box or on a computer screen, you want the humerus to be in the same orientation for all four views. So I'm going to rotate my IR so that the long axis is running with the long axis of his humerus, the same as it was for the AP in both obliques. Okay, turning the hand to a lateral position ensures that I have the correct orientation. This is going to show the humeral epicondyles superimposed. Olecranon process is going to be in profile. He's 90 degrees. Humerus and forearm are on the same plane. And now I'm going to take my tube and center it over the elbow joint. I want to get about 3 inches beyond the elbow joint in both directions. Okay, place my right marker and expose. The first projection that we're going to demonstrate with you getting the patient onto the table. So there's a lot at stake here. We need to make sure that our patient is safe at all times. You need to assess their mobility, assess if they're dizzy, if they've had any pain medication. All kinds of extra things come into play here. And so when you're escorting your patient into the room, you want to make sure that they are capable of getting up onto the table with minimal assistance. Otherwise, you may choose to do this a different way. Get a different, all right, so I have my patient over here. I'd like you to use the step stool here, stand up, turn around, and just sit down on the edge of the table for me. And I usually kind of keep my hands close so that if they stumbled, I would be right there to assist. All right, so for this, we're going to be x-raying your upper right arm. What I need you to do is lay down on your back with your head on this pillow right here and feet down to the left. Okay, very good. All right, now I will need you to slide over to the left edge of the table. That's fine, right there. Adjust the pillow here just a little bit. Okay, very good. Now, put my shield on, and I'm going to utilize a 14 by 17 cassette. So because of the length of the humerus, depending on how tall your patient is, they may or may not fit on the IR lengthwise. Now it looks like from the top of his shoulder to his elbow joint does not exceed the 17 inches of my IR. But if it did, I have the option of putting the humeral head here and having the humerus come out diagonally across the IR. So I'll show it both ways, but I'm going to start out with him just in the long axis of the IR, because I think because of his height, his humerus is going to fit. You're right on the edge of the table here, but I do need you to roll towards your left side just a little bit for me to push this plate under your back. Okay, roll back. All right, now what I want you to do is just lower your arm out to the side here. I'm trying to get it roughly down the center of the IR. Again, you can do this diagonally, but we're going to start out doing it this way. I want at least an inch above his humeral head and at least an inch below his elbow joint. So he is going to fit on this lengthwise. But to actually set this up for the demonstration, I'm going to have him, we're just going to be diagonal. Okay, so the IR comes to a point right about here. His humeral head is within the IR, so I've got good clearance here, and then his elbow in an AP position. Now you're going to find when you're in the clinic, patients that have humerus injuries, 9 times out of 10, unless they're on a backboard and can't stand, they're going to be much more comfortable done in the wall bucky, because laying down puts a lot of pressure. But the book shows it both ways. We're just going to demonstrate it supine. All right, so you can either rotate the collimator head, or you can turn the whole tube utilizing the purple button. Okay. And I'm lining up my light field with the long axis of his extremity. Okay. And I want to be sure that I've got an inch of light all the way around. This is pretty close up here. Okay, so now you're going to see there's light field off the cassette. That's because I'm putting a, roughly square light field on something that's a triangle in the corner, but that's okay. His whole humeral head now is within the light field, and I've included just past his elbow joint. So this is our AP view with my right marker here, and I would expose it that way. Then for our lateral, what I'm going to do is have him internally rotate until his humeral epicondyles are perpendicular, and he's going to put the palm of his hand on his hip. Do that. This is much, much easier done upright.
Ow.
Yeah.
Oh.
Okay.
Ow.
So.
I'm serious.
It's not comfortable. It's much better done upright. Okay, so this is our right. Now,
I've never done them laying down.
yeah, and I will demonstrate this upright as well. But you want clearance around the whole humeral head, at least an inch above, and I'm including beyond the elbow joint. So that's our lateral. You can relax. So I want to be sure that you guys are aware of how to put an IR in the bucky. This little shelf is inserted at the level of the lengthwise dimension, or whatever, however you're placing this. So if it's lengthwise or crosswise you would put it at the 10 mark, lengthwise at the 12 mark. So you find the 12, you insert the little legs and then drop it down, and now you have a little shelf that you can set your IR on. Okay, so the other option for doing humerus, that is most likely what you will be shown in the clinic because it's so much easier on the patient, is to utilize the upright wall bucky. So this requires that we do some manipulation with the tube, we've got a green rotation button and a purple swivel button. The green rotation button takes you from vertical to horizontal. So we're going to turn this until we get a 90-degree readout. It sort of locks in place. And then we're going to push pink because we've got our pink arrows that show the direction that you can move when you're pushing this. So we were going to depress pink, and we're going to bring it in to 40-inch SID. You'll also feel it kind of lock in to place, and your readout should be 40. It's 39.9, which is close enough. All right, and then we're going to utilize orange to center it to our ball bucky. Now, you'll notice now that even though this is centered, it's not lined up here, which means that my swivel button is off slightly. So I have to get everything lined up there. All right, so I'm going to set this up mostly so that I don't have to do much additional manipulation once I get my patient set up. I'm going to utilize a 14x17 cassette. So it just sits on a little lip in here. You push it in, and then when you draw this together, it clamps from the other side. Once it stops moving, you lock it in place, and then push the bucky all the way in. Okay, I'm going to have my patient come over. Now, I'd like you to stand with your back against the board here. I'm going to look at where the top of his humerus is, and I'm going to adjust my light field so that I'm about 1.5 to 2 inches above the top of his shoulder. So once I adjust the tube, now I'll adjust the bucky so that they line up. All right, and again, I'm going to do this diagonally, so I'm going to center him, and so I want my light field to go just beyond his humeral head. Step to your left just a little bit. All right, so my humeral head ends here. My light field is about 1 inch beyond. I'm 1 inch above here. And now when I come out and I extend his elbow, now his humerus is going diagonally across my 14x17 IR. But my light field goes past his elbow joint. Actually, I think I'm going to bring this down just a little bit. That looks better to me. Okay. So now he's in an AP position, and compared to laying down, is this much more comfortable for you?
I love it.
All right, I'm placing my right marker on there. What you're going to see done in the clinic oftentimes is also a rotation of the x-ray tube so that you can collimate in side to side further. We'll not be doing this in our demonstrations because, it just takes a little bit more mastery of the equipment. So for our purposes of simulated evaluation, we're going to be leaving it open to roughly a 14x17 with the humerus going diagonally across the IR and the central ray entering about mid-humerus. Now for a lateral, if I rotate, and before I exposed him, yes, I would bring in my rolling shield, okay?
Thank you.
All right, so for our lateral, we're going to roll his arm until his humeral epicondyles are aligned. Now, you can see how much OID I've created, but it's important that the humeral epicondyles are superimposed. So to do a humerus lateral in the upright bucky, the best way to do this is PA. So I'm going to have you turn around, face the board here. Now, just kind of lean in. So now his humeral head is in the light field up top. Place your hand to palm on your thigh and drop your hand just a little. Humeral epicondyles are superimposed, and now his arm is very close to the IR. I don't have that OID like I did in the AP position. My light field goes beyond his humeral head. I've got light up here, light below the elbow. I can invert my marker now so that when I'm looking at the finished product, my R is facing straight. All right, I'm going to bring in my rolling shield and I would expose. And again, if you were in the clinic, they're probably going to want you to rotate the tube head and collimate inside to side.
So for the shoulder, we do the shoulder upright. So I have my patient against the wall bucky, and now I'm going to make sure that I am aligned and detented with the wall bucky. So I'm going to detent transverse. And then the shoulder is done at 40 inches. So I'm going to look up here to my 40-inch mark and detent longitudinally also. So we're adding another detent in here, not just this way, but also this way. And then I'm going to turn my tube so it's facing my patient. And so a good way to check that you're detented and aligned is just to see where your crosshairs show up on your bucky. So,
And it could be the purple's off too.
yes. There we go. And then before I align this way, I'm going to look at my patient and look at where I'm going to center on her. So we center 1 inch below the coracoid process. So the coracoid is in this kind of dimple here on the shoulder. So I'm going to go 1 inch below that. I'm going to have you step to your left just a smidge, right about there. Good. And so now that I'm centered this way, all I'm going to do is bring my bucky up to meet it. And I'm already at 10 by 12, but I'll come out to show you that I've collimated to the size of my cassette. I have a little bit of collimation on all sides. I'm going to go ahead and place my right marker and the shield. And for the first one, the neutral, you're just going to leave the patient's arm in a neutral position. So it's just going to be hanging at the side. Double check one last time. I want to make sure that I have light, about 1 inch of light above the shoulder. I also have light all the way to the jugular notch. I'm going to bring you over just a little bit, there you go, to make sure that we get the entire clavicle. And then you can also just make sure that you're getting in the bottom of the scapula by feeling the bottom of it, which is right about here. So I'll definitely get that in the light field. All right, I'm going to have you turn your chin just slightly to the left. Good. You want to make sure that when they turn their chin, they're also not turning their body. And you just want it out of the way a little bit. And right marker. All right, so I step away. I'm going to have you please hold your breath, don't move, and expose. You can go ahead and breathe. We're going to stay in the same position because the internal and the external rotation look very similar. So for the internal, we're going to turn the patient's hand until the back of their palm is touching their thigh. And nothing else changes. So if I'm using CR, I just change out my cassette. Everything else is already aligned and detented. All right. So I'm going to have you hold your breath, don't move, expose. Okay, go ahead and breathe and relax. Now I'm going to have you turn your palm so it's facing forward. And when I'm doing this, I'm also checking the epicondyles to make sure that the epicondyles are going to be parallel to the film. All right. And this is the external rotation. Go ahead and hold your breath, don't move, and breathe. So now we're going to do an axillary view of the shoulder. So if your table goes down really low, sometimes you can do this with the patient seated. In this case, I think we're going to have to do it with the patient standing up, and I'm going to show you why in just a second. So I'm on tabletop, I have my 40-inch SID, so on the readout it reads as 43 inches because it's 43 inches from the bucky, but that means that it's 40 inches from the tabletop. So I have a 10 by 12 cassette, and it's going to be lengthwise to the part, which is going to be the humerus. We have a shield for our patient, so normally we would have that Velcro. So I'm going to demonstrate it for my patient first. It's a little bit easier to understand it that way. So what I'm going to have you do is you're going to take your, we're doing your right arm, is that correct? You're going to take your right arm away from your body and lean down over the table like this. And what I'm trying to do, and I'm just going to move this underneath you. What I'm trying to do is get the glenohumeral joint in the center of the cassette. And you know you're in the glenohumeral joint. I'm going to move the table a little bit towards me because the tube won't go that far. Good. So we're trying to get the glenohumeral joint in the center of the cassette, and we want to make sure that her head is out of the way. You'll know that her head is out of the way because you won't see the shadow of her skull on her shoulder.
Which would look like this if it wasn't.
Yes, so you can see there's light in her hair, and you can see that there was no shoulder. If you can't see the top of the shoulder, then you know that the head's in the way. So we're going to center at the glenohumeral joint. We're going to collimate. I'm going to add a marker. And she has her shield. If your patient was greater than 10 centimeters of thickness, you might add a cassette grid on here. If they couldn't get their arm out really far, like Julie's very flexible in that way, if they can't get their arm out very far, sometimes you might throw an angle on the tube. The
So
angle is,
maybe I could only do this, then she would angle to project it.
so if you can't get your elbow out far enough, let's show them an even more obvious one. There you go. So she really can't get her elbow out far enough to get the cassette all the way in because her rib cage gets in the way. So in that case, I would put a short, very slight angle towards the elbow to get that glenohumeral joint open. So that's the only thing that might change. Because she is very flexible in that way, we're going to go ahead and do it with a perpendicular angle. I'm just going to move this a little bit. There you go. All right, and move this down to 43 again. All right, and hold your breath, don't move, expose. Okay, go ahead and relax. It's not a comfortable position for your patient to be in, so it's a really good idea to kind of have everything aligned and set up before you have them put their arm all the way out.